All right. We're recording, Nick, if you can hear this in the background. Nick Previtt, that is. Okay. All right. Once again, for those that may not be aware, the top right of your screen, you have the speaker view or the gallery view. You can do that based on your preference. And with the conversation, let's try and use the raise hand function. So I don't know what that looks like on your end of things, but there's a raise hand function. We'll kind of let that guide the conversation of who's going to be talking. We did good last time though, so I don't think it's going to be an issue at all. So all right, let's open up that PDF. I'll put the link in again because I don't think the new people get to see it. So go ahead and pull up at least week 4 and we'll start on week 3. So the fun stuff, this is the stuff that a lot of people, when they sign up for this course, this is what they want to geek out on. But we have to talk about the important stuff in terms of ageism and clinical geriatric syndromes and functional measures before we get to the squat and the deadlift and exercise program design. Raise your hand if you had a harder time than what you thought writing that 3-week program. Yeah, and I'd raise my hand too, because it forces you to put your thoughts down on paper and you really start to question, why do I want to do this? Why am I keeping the weight the same? Or why should I go up in reps? How should I progress this? And some of y'all mentioned that on the assignments, and that was pretty cool, because we want that exercise to be very informative for you, because we stay in our heads so much that we don't really plan out 3 or 4 weeks in advance like many fitness professionals do, for example. So it's cool that you all got to see that.
Yeah, so I was actually this week, I was in Toronto, Ontario, speaking to inpatient and outpatient geriatric and neuro PTs through Providence Care. And this type of very thoughtful and objective progression and exercise programming came up as one of the things that we as geriatric physical therapists probably don't do as well as we should. And I asked the room, there was about 45 PTs there, and I said, how many people systematically and very thoughtfully progress their exercise programs in one of these ways? And it was specificity, volume, progressive overload, those things that we brought up in week 4. And there wasn't a single hand that had gone up. And you could tell that this was like this light bulb moment happening for these people, because they're like, oh my gosh, like I actually don't do that. Like I don't think about it when I'm working with some of my older clients. And so we started having these conversations, and it was funny because some people didn't even want to make eye contact with me because they're like, yeah, shoot, like I don't do that. And I don't think that's an uncommon thing. I think it's something that we need to be talking about more and teaching our students, because one of the biggest things that I see is that my students can tell me what the exercise prescription guidelines are for a community dwelling older adult or some of the more chronic conditions like diabetes, cardiovascular disease, and they're very similar. Mm-hmm. But actually applying those principles into a program and working towards hitting those guidelines is really, really challenging, and something that I don't think we get a ton of exposure in PT school at. So,
yeah, I would agree. 100%. All right, well, let's start with that assignment in mind. Let's go through some of these week 3 questions, because I think that would be helpful. So with Anna and Doris, which Christina got to hang out with Anna today. I don't know if you all follow her on Instagram at the baby shower. Anna was present. But the first question, how would you accommodate for Anna and Doris, their yellow lights in your programming? So we learned with Doris, at least, hypertension, osteoporosis was a concern. Anna as well, she has a history of breast cancer. So as you all were doing these programs with this assignment, how did you accommodate for some of those yellow lights, the things that you wanted to keep an eye on, that you were somewhat concerned about, that kind of influenced what you did and why you did it? Any takers? Did you all think about that?
Yeah.
I guess I will just say that, I did my program for Doris, and I was thinking about, you know, her osteoporosis. So even though I didn't like explicitly write it out on every single exercise that I did, that was one of the things in the back of my mind is, you know, I added like a forward reach with a hip hinge just to make sure that we had good form, you know, that you're protecting and maintaining safety with osteoporosis precautions a little bit.
Right. So you didn't do, you know, 1 rep max deadlift day 1 to kind of get her base. Okay. That makes sense. Yeah. And I didn't see that with anyone's program, which, you know, I think it's so subconscious for us. And so just kind of, osteoporosis, I'm not going to start here. You know, I'm going to, you know, teach the hip hinge, for example. But these are things, you know, just that we want to make sure we're identifying in this course, just so people that may not be thinking about that, you know, they do bring that to their attention. Any other things that y'all were thinking about as you were doing your program in terms of the yellow lights? That was a good one, Jennifer. Is that Andrew?
I think just monitoring like blood pressure, heart rate responses while you're doing some of the warm up and exercises to make sure that, you know, with hypertension, especially I had Doris, and with her questionable medication interactions and all those types of things, to know for sure that, you know, she was actually appropriate to continue working at that level.
Yeah. So practically speaking, I'd like to hear your all's thoughts on this, because I've been kind of toying around with different methods. When you are monitoring at least blood pressure, what are you typically using if you're trying to monitor that, you know, during or in between exercises, you know, like during rest periods, for example? What do y'all
in my clinic, we have just an automated cuff that when they're taking a rest break, like a seated rest break, I'll just hit the start button, leave it on them while they're doing some of the exercises, reattach it, and then try again.
Yeah, an axillary?
Yeah.
Okay. Avery does the manual, tried and true. Anyone do wrists? Yeah, the lazy part of me uses the wrist a good bit after I do a manual initially. But yeah, there's just so much variability that yeah, it's just kind of this isn't good, and I'm not recommending this. But if there is something off the charts, then I'll go to the manual. But I think as I've been trying to compress the rest periods so much more, I'm just like, I just want to hit a button and be done with it. But I just wasn't sure how, you know, you all kind of go about it. But I only have a manual and I have the wrist, so it's usually a hybrid. Yeah, wrist is flaky, and I've never experienced the more expensive ones either. I've always just kind of had kind of the mid-grade, you know, just kind of mid-quality. I've never experienced the high-quality ones that you pay a good penny for. Haven't got to compare those. That's good to know, because we talk about this a lot. And I've never had like an automatic axillary. Like I've never been in a facility. It's always been either a wrist or a manual, in home health at least. So that's good to hear what y'all are using.
Mm-hmm. What do you guys think about some of the responses to resistance training? Because we have an expectation that our blood pressure will increase on exertion. Do you guys tend to look for trends across? Are you reaching a critical threshold? Like, for example, this is obviously not in a geriatric population, but transiently with Valsalva, your blood pressure can spike to 200 very safely and then come back down at the end of a heavy squat set, for example. Do you guys kind of take that into consideration? If it's a little bit elevated from start, are you worried about that? Would you stop at any point, even if it's just for a little while, or would you take a sequential measure? What do you guys kind of do?
Is that Aaron? Yeah, raising your hand. I hear you.
The biggest thing that I look at, can you hear me?
You're muffled, so if you maybe come closer, and that may be a little better.
Okay. How about now?
Yeah, it's a little better. I mean, we can hear you. It's good.
Okay. The biggest thing is because you're like, I'm usually giving geriatric population a little bit more rest in between sets. So I'm kind of looking for a little bit more of like a recovery blood pressure than I am like peak blood pressure, because a lot of times it's going to have that spike. So if you're giving them, 90 seconds to 3 minutes, I kind of am looking more at that 2-minute mark. Have they maybe began to trend down a little bit with that recovery?
Mm. That's a good point.
How long are your rest periods, Erin?
Huh? What was that?
How long? You said your rest periods were a little bit longer. Like, how much rest are you giving in between?
So usually what I'm doing is if I'm doing like a heavy strength skill, I'm doing like a 1-to-3 or a 1-to-5 work to rest ratio. And then if I'm working more like balance or endurance, I'm usually doing like a 1-to-1, 1-to-3 work to rest ratio.
Okay. Avery brought up a good point. He's probably got 3 kids running around. It's a circus over there. But Avery says, go off their symptoms. Exactly. If they're having difficulty, then I adjust. If they are tolerating, then continue. This has been a big lesson for me. And I mean, some of you all may echo this, but especially like coming out of school and even in some of my acute care rotations, the vitals, you learn to fear them, especially I remember the 160/90 number. And if someone was over that, I would freak out and say, well, we can't do therapy anymore, as it was this cutoff for physical therapy or exercise. And then I met my wife, and having her perspective has been super helpful. She's an emergency room physician, just to hear how they handle blood pressure. I mean, if someone could be in the 220s over, 120, for example, and if they're asymptomatic, they're just going to hang out and watch them. I mean, it's not this, we need to intervene kind of mentality. But the symptoms guide so much of the treatment. And then with a lot of the physicians that I have called freaking out about 168/94, and they ask if they have any symptoms, and I say no. They're like, oh, they're fine. Just track their symptoms. That's the overwhelming response that I've gotten from the primary care docs, and then definitely the ER docs that some of us may have referred to, called 911 based on high blood pressure. But yeah, a lot of times the physicians, they're more concerned about the long-term trends if they're running that high for a long period of time versus, that acute glimpse, into their hypertension. But that's been freeing for me, because I feel like I can push them a little more, just monitor symptoms for those that do have an accurate subjective report, which not all of my patients do. But that's something we got to consider. What are you going to say, Christina?
I think we're seeing that in the literature too. Mm-hmm. Where the ACSM guideline for medical clearance for exercise used to be any sort of cardiovascular risk factor, including slight hypertension, that you needed to go for a cardiac stress test, go see your primary care physician, et cetera, et cetera. And then what they saw was that was such a barrier to starting exercise. And the benefits of being active on regulating that blood pressure was just so much higher. And if we're getting people to wait even 4 to 6 weeks to go through that testing procedure, that it wasn't worth it. And so they really revamped the guidelines, I think in 2016, to say that, very rarely, unless there's like an acute MI or some sort of cardiovascular event, do we actually need to have a full stress test before starting any sort of aerobic program?
Yeah.
Jen?
Yeah, I just kind of had a quick question, since we're talking a little bit about blood pressures. You kind of said at the beginning, you expect your blood pressure to kind of rise when you're doing physical activity, you're doing aerobic activity. But when we were reading one of the articles, it was talking about how aerobic exercise can evoke like a drop in blood pressure. Mm-hmm. So I'm just wondering, like, as we're working with our patients, I mean, what should we be seeing, a rise or a drop in blood pressure? Or is it both, or still going off symptoms,
Yeah, it's usually an acute, it may be an acute elevation. And that's why, especially with aerobic exercise, you will see a drop. But like with, resistance training, you'll see that acute raise, and then you may see a drop afterwards. But by the time we check it, typically there may be a drop. Like I've seen people on the new step where I've thrown them on for 5 minutes, for example, and we'll have a drop of 10 on the top and 5 to 10 on the bottom after that type of activity. So it's usually a quick jump to accommodate for that increased load
Okay.
and demand. And that's something too,
Nikki
I think.
said,
Sorry, go ahead.
go ahead.
I
I was
think
just going to read Nikki's comments so you can finish up.
And that's an opportunity. Christine's on country internet again. For a lot of our folks that are afraid, there's a lot of fear involved with their hypertension. And, when we may talk about, exercise can help with this, that's a great way to build a bike. Throw someone on a bike, a new step, go for a walk, pre and post blood pressure. And, if 5 minutes isn't enough, 10, 15, maybe go a little longer, and you can demonstrate a drop, and that can be a powerful, sign to them that, this stuff actually does have an impact on something that they may be worried about, like hypertension. So I'll read Nikki's comment. Sorry, Beth, I'm over here. That's what I do. I monitor, and if they are high initially, anxiety, cognition, I'll use relaxation techniques by just chatting with them and check again about 3 minutes later, and it usually decreases. Obviously, if it trends high with each visit, I reach out to PCP. Yep. PCP, our good friend. I think they hate us a lot of times because we're calling so much and asking for orders. But some of them do appreciate us calling. Cool. All right. Let's go back to the PDF here. All right. So you established your goals. We did this awesome exercise program. What's some of the education that you would give, to Doris and Anna, for example? And I think in particular, Anna, because she's in an interesting situation. What education would you, for those that had Anna, what would you make sure you preface before you start that exercise program that you created?
Erin has her hand raised.
All right, Erin.
Kind of the one thing that I read on Anna's on week 3 is how she's never been on a strength or aerobic training program, but her kids are really big in CrossFit. So I think she's probably terrified of working out because she's seen her younger kids do what they consider high intensity. So she's probably like, I can't do that. What are you talking about?
Mm-hmm.
So I think I'd really educate her about how intensity is subjective and how we're going to work at her intensity and build her strength, but not necessarily work at what she's used to working. That was the big thing that I got on week 3 that was key.
Mm-hmm. Was that pretty accurate to real life, Christina?
Oh, yeah, absolutely. She had never done any sort of exercise in the past. And so what to expect, like with post-exercise soreness and why we were doing these type of exercises, throwing it back to exactly what was important to her, which was being able to do her kids' laundry and go upstairs with a laundry basket was super important. And I think that there are certain semantics, especially in the world of geriatrics, that can be very fearful. And the two of them would be power training and high intensity. So people assume when you say power training that you're doing clean and jerks and snatches and that you're some sort of weightlifter, when really it can be let's squat fast versus squat slow. And that is a way to incorporate power training into a program for a geriatric population. And exactly what you said, Erin, around high intensity, that high intensity, even if you are doing CrossFit, the CrossFit in high intensity as a 20-year-old versus a 70-year-old, it changes in degree, not kind, right? Going right back to that Glassman quote. So we just have to almost like work through some of the potential stereotypes or considerations for that type of programming and what people automatically assume with the high intensity word. So that is like bang on, Erin.
Yeah. Did you tell Anna we were going to talk about her tonight when you saw her today?
No, I didn't.
No.
But I should. So
did you tell
I
her?
wonder if I push this, I can put the picture.
Yeah, there's 14 people from all over the world that are physios or educators that are going to be talking about you tonight, Anna. That's awesome. Mike, go ahead, Mike.
I was just going to say I assume she was pretty freaked out about her knee pain and a lot of possible fear avoidance towards activity because of the risk of flaring that up. So a lot of education to try and just help her realize that it's probably going to help.
Yeah. How does that conversation go? Because there's probably going to be some type of hurt or soreness or whatever. How do you actually say that to them to, you know, give them a clear idea of what to expect?
For my clients, I usually tell them that they should expect soreness. There's good pain versus bad pain. So bad pain is anything that's really sharp or intense or essentially quite acute. But if they're and also if they're getting any kind of that delayed onset soreness that lasts probably past 48 to 72 hours, we usually know that we probably program them a bit too intensely to start with. But yeah, they should expect to have some soreness in the next day or two, and that's a normal reaction, especially when you're starting something new or adding new loads.
Yeah, that's solid, and that would translate well to the American context. I mean, if I had your accent, it probably would help a little bit better, but
yeah,
the
like
same words.
accent. Very true.
That's awesome. All right, what about Doris? How would you preface your program with Doris? I don't know if this came through on the case, but Doris is the kind of person that could really, you know, sometimes give two shits if you're working with her or not. Just kind of like, I'm fine. I don't need your help. PT doesn't help. I'm good. She, that kind of woman. How would you preface your program?
Yeah, I think a lot of the education is very similar to what you would do with Anna in terms of just telling her, expect that, you know, you've never exercised, you're going to be sore, and trying to maybe explain the difference between delayed onset muscle soreness being a normal response, that she's not actually damaging herself. Because a lot of people, when they experience pain, they're afraid that it's causing like some sort of physiological damage, that they're hurting themselves. And so let it might be pretty important for her.
Yeah. Yeah, that was a big conversation for her. Yep. Kevin?
I would just say, like, being clear as to, like, why you're prescribing what you're prescribing. Like, whenever you're doing, like, going to, like, the program and you're, like, educating on the techniques or whatever you're describing or prescribing, making it clear the correlation between this exercise and the ability to do X, the ability to get up off the couch or something like that.
Yeah.
I think the more clear you are on that, and then, you know, like showing that at the end whenever she's actually done the program or something, that she can do it better. I think that kind of would help. But
yeah, for sure. I mean, that right there, I mean, I remember, I mean, I didn't write out a you know, multi-week plan like you all just did, but just trying to lay it out on a sheet of paper when I gave her first home exercise program of, you know, this is why you're doing these sit to stands from this elevated surface. And by the end of our time together, you're probably going to be able to do, you know, X, Y, and Z, you know, with a weight. But just really making that path of where we're going as clear as possible for her to get that buy-in. Because what was she used to? She was used to the green, you know, slingshot, just doing a bunch of random movements with the band in her couch or recliner or whatever, and didn't do anything for her balance, which she was concerned about. So yeah, clear path, making it very easy for her to understand is huge. Yep, Emily. Hold on, we don't have any audio. Let me unmute you. Yeah. If you're on a computer, if you go to the bottom left of your screen, there's kind of the audio portion. If you hit that up arrow, there's you can select a microphone. There may be a different microphone that you want to select. Or if that doesn't work, you can just type it in. Oh, Doris. We I had the Facebook memories, 3 years ago today, you were blah, 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 blah. She came up, I think it was a week or two ago, when Megan, my wife and I, we were planning our big European trip in between her starting her job and after residency. And Doris had traveled all over the world, and she told us, where we needed to go in Italy and where we needed to go in Switzerland. And she had us over for dinner and a bottle of wine. And that picture came up. I almost shared it with y'all, but I just decided not to. I just saw Avery's comments. I'll read that. So for Doris, we need some buy-in concepts. Also walking her through RPE and know we can stop if it is too much, definitely. And not just showing her the scale, but as Avery said, walking her through and equating, what does, a 6 or 7 feel like, kind of, where we may want to be. Buy-in could be as simple as working through some active range of motion knee movements that helps decrease pain with squatting or priming the system to help with balance with some warm-up or loading. Yep, building the bike. That's good stuff. Emily said, important to give a time frame roughly for when the patient may start seeing significant change. Yes, as well as importance of compliance and consistency so that the patient knows it's a process. My goodness. That's a big one. The process, it's not a pill, it's not a surgery. It takes time for adaptation, for sure.
It's like any sort of gym program. You don't expect to see results sometimes people expect to see results overnight, but in general, we're waiting 4 to 6 weeks before we see any sort of meaningful change. The same is true with the rehab program that's focused around strengthening.
Yeah, it's like we need to set the stage to have a realistic perspective of when we are going to see change, but then we also need to demonstrate change as quick as we can. So I think it's an and not or scenario there for sure. Yep. And Avery said, preach, Emily, out of this conversation, I feel most days. And that's a good concept in life in general. It's a process. You're not going to get the results you want overnight with most things. It's all right. Let's go on.
What do you mean? We're not getting instant gratification?
In some things, I guess. Yeah. I don't want to put in the hard work. I'm just kidding. All right, let's go on to week 4 with Christine and her country internet out there.
I'm so sorry. I was actually just at a baby shower, for my little one, and my parents are 3 hours away. So I usually try and get into a coffee shop so that you guys don't have my horrible delay, but I didn't end up having time to get back before we were starting today. So I apologize for the delay.
I'm messing with you.
Okay, so for the week 4 assignment, I was so happy to see so much variability in the programming, so much discussion about this assignment. So does anybody have any comments before we get to some of the questions? I loved Kevin's post asking, is there a way that we can systematically think through this so that it becomes more second nature? Kind of, Kevin, what prompted you to post in the group?
So when I was making my program, it took me, I feel like, an hour and a half or something just to come up with all the different things that I was just thinking of through. And like Dustin started off saying, how many repetitions and why am I doing it from this or setting this intensity or whatnot. And so I was just trying to think of if there's any tips or, anything that anyone had any ideas on, how we can facilitate that better for more experienced therapists. I'm still pretty new, so I didn't know. And I'm not in really home health or kind of outpatient setting where I make a lot of these 4 to 6 week plans and things like that. I see it in the acute setting. It's you may be here a couple days, so what can I do to facilitate or whatever? But so I just was looking for some thoughts.
Mm-hmm.
Did anybody have anything that they could kind of say? I had my own opinion, but does anybody have any kind of comments to that?
Yeah, Mike's got his hand up.
Oh.
Yeah, I think you've just got to treat it as a bit of a relationship. and grow over time. So I have a coach for triathlon, and it's taken us about 2 years to really kind of nail down what I need to do in probably my monthly cycles to progress through my sport. And I'm not saying you're going to take 2 years with all your clients, but for you in acute care, it may just be helping set the expectations. You know, when they do move on to a practitioner in the community, whether it be outpatient or home health, just kind of helping people recognize that it's not going to be something that happens overnight. It goes back to that instant gratification side of things. And my experience as a manager in physio now is physios tend to have a bit of a perfectionist personality trait. And we sometimes get a bit stuck on the plan has to be perfect from the start. And that's just not the case. Like you kind of have to start with a plan, see what the response is. And then if you have to edit the plan, you have to edit the plan. And eventually you kind of learn what people can and can't tolerate and make progress. But it takes time to do that.
Mm-hmm. I think too, it's interesting, especially like, I love what Mike said in terms of, you know, just like we think there's a perfect way to do something. And it seems like every month or couple months, you know, we're coming across a new research article that, you know, may challenge our bias in terms of how things are gone about, exercise sequencing, for example. You know, there was it last week, I think Alan shared it with us. I don't think it made it into our Facebook group, but looking at, you know, should we start with some of the isolated, you know, single joint exercises first in the session or at the end? You know, we've advocated for, you know, do the bigger lifts first, like the squat or the deadlift or some of those multi-joint type movements. And this study found that, you know, both sequencing got results. You know, the big part was that people we needed to load them. You know, we needed to load them appropriately. It didn't matter if you started with, you know, long arc quads with a TheraBand or you were doing, you know, a kettlebell goblet squat, which challenges my bias tremendously. But it is true. Like, it seems like with this population that we're trying to serve better, you know, loading and intensity, you know, seem to be a big deal. And there's so many variables that we can play around with but still get awesome results. Alex said, oh, never mind. Yeah. That was on a different screen. What were you going to say, Christina?
Yeah, I think like the easiest way that I've kind of gone through with the programming is with whatever day the person is coming in to see me, what is their number one goal? So if we're using Anna as an example, it's to be able to go upstairs with load. So the first thing that I'm going to be doing is step ups with or without a load, depending on where I'm at in her programming. And then from there, what are some of the residual weaknesses that we may have seen either through objective assessment or through compensatory action in the step up? For example, is she starting to, like, you know, kind of almost Trendelenburg her hips, so that I'm saying, okay, so there's probably some underlying hip weakness going on there. So from her main exercise, then I'm going to be doing supporting exercises back up to the first one. So that could be like monster walks, that could be banded squats, that could be something that's going to prime some of her hip musculature just to fatigue her and get that progressive overload stimulus. And if you took a look at all of the different programs, they were all fantastic. And they were all coming at it from a slightly different angle. And it's not the and not or, like, there's so many different ways to go about the program. You'll have your own biases. I have a bias in terms of how I will progress. The one thing that I was laughing about with the multi-joint exercises, I'm like, of course, it's 3 sets of 10 to 15. Go figure.
Yeah.
Because I tend to use a lower rep range and load them higher. Yeah. I was like, you're hypertrophy training on both angles. Like, oh, go figure. You're progressive overloading by 3 by 10 to 15 and progressive overloading by 3 and 10 to 15. Oh, sequencing by volume is exactly parallel, of course. Like, they have the same results.
Yeah.
But that's me geeking out from a research perspective. But yeah, there's just so many different ways. And the more you do them, the more it just like becomes almost like second nature. But I thought that was an awesome question. Okay.
Yeah, repetition, and as you experience it as, you know, an athlete or as in your training, in your resistance, exercise regimen. I feel like that has informed me tremendously. Granted, how I feel things may not be the same as, an older adult, for example, but I mean, it helps me put myself in their shoes to some extent.
Okay, so what are the questions for week 4? What would you do to prevent aches and pains, ensure adherence, and maximize buy-in for your program? We've talked about this a little bit. But the preventing aches and pains, I think, is a big one.
Brian?
Yeah. So the first visit, I would start a little bit below where I think they could probably tolerate, just to kind of get that build up, just to kind of, acclimate them, especially if they're not used to activity. I always joke around with my patients, I'm going to take it easy with you today because I want you, I want to be invited back into your home. I don't want you to not want me to come back. So that, and then on top of that, throwing in manual therapy techniques, joint moves, stretching, just, anything to kind of help with pain modulation.
That's awesome.
Yeah, absolutely. I like that too. And I've also done this extremely poorly. I have had clients who have come in with low back pain, and she had some stenosis. We did like 1 minute of walking, 3 minutes of rest, some sidestepping, and a couple of marches on the spot. And I was like, oh my gosh, I have underdosed this program. Like, I almost feel bad. Like, I underdosed this program. She called me the next day and was like so muscle sore, like had so much muscular soreness that she didn't want to come back. And I was thinking, oh my gosh, like she could have done so much more. I've underdosed this program. And she was like, this crazy physiotherapist just made me super sore. There's no way I'm going back. So, sometimes even when you think you're underdosing, you're not. And so there's trial and error. And I feel like as I've done this more, I get a little bit of a faster mark on where I need to place them. But I still make mistakes.
Yeah.
And have to backpedal.
Mike?
Yeah, I think this applies to geriatrics, but possibly just to working with people in general. And that's just making sure you take their whole life picture into account with this. And I know from my athletics, it's a lot of, or triathlons, it's there's a big part of it, which is essentially managing the whole picture and nailing the basics around sleep and nutrition. And I have this conversation a lot with our new grads. Like, there's no point in loading someone up with big elaborate exercise programs if they're only getting 3 hours of sleep a night and not eating enough. So just I guess some of the education around actual healthy lifestyle, but also the supporting habits for being able to get the benefits from the exercise is pretty important, and also does help to prevent with the aches and pains a little bit.
That's a really great point. And especially for our older adult population, the drive for drinking goes down. So thirst drive goes down. So dehydration is a higher risk when we're older. So, and that could affect recovery for sure. And then the other thing is that protein intake tends to go down, and we need more protein as an older adult than a middle-aged or younger individual does in terms of recommended daily amounts. Even for a completely sedentary individual, we're not really talking about the athletic population. And so if they're not really eating a ton of protein, their muscles aren't recovering either. And there's actually some pretty good literature about creatine supplementation being very, very helpful in an older adult population, which we tend to think is more for resistance trained younger adults, but that's not necessarily always the case.
There's something just come out, right? I think this week about creatine. It's on my to-read list. I don't know if I saw you share it. This is a difficult conversation, I feel, because I remember the gym owner that I used to work for. So Christina, you may be able to speak to this, and Mike too, you know, if you're working with, you know, the athletic population. But at the gym, you know, people would come into the door and they would want change. And typically it was driven by weight. You know, they wanted to lose weight. And we were always racking our brains on what comes first. Does the exercise hook them in to give a crap about nutrition and sleep and all these other things that we know are important? Or do we focus on some of these other factors and then they'll really care about exercise? You know, what's kind of the lead domino that will influence the rest of these behaviors that we know, you know, are good for people? And, you know, it obviously changes with each person. And I never developed the skill to be able to tell, you know, what would be the lead domino. Like if I get this person exercising, then I know they're going to start to care about what they're putting into their body. You know, I can never figure that out. But that's just something that I think about with people. Like what would be the lead domino that would influence these other behaviors? Which that Mike Eisenhart could probably go off for, you know, 5 hours on that. But what are your all's thoughts on that?
I think you can make a point of asking it at the start. So when I do my programming for people, I actually ask them, how much sleep are you getting? How would you rate your diet? And then it doesn't stop me putting exercises in place, but it definitely helps with putting in that initial intensity around it. Because if, like say, if they're coming back and all these basic underpinning factors for growth, you know, protein synthesis, muscle development, etc. If none of it's there, and then you give them something that really loads them up intensity wise, they're probably going to be sore for the next 2 or 3 days, and you're really going to use that buy-in for getting them to come back. So I think you always got to look at that whole picture. But yeah, from my end, even though I'm a physio, I still think the nutrition and the sleep and the just basic they underpin what you can get out of your actual exercises. I think from my experience when I was a grad through to now, that's something that I've learned and recognized a lot more.
Yeah. And which can be an issue for so many of the people that are in facilities where sleep is just not a thing. Like Kevin, for example, you know, like it's such an unrestful place. Sorry, Christine, I cut you off.
That's okay. In some circumstances too, though, when I have some of my clients who are completely sedentary, part of the reason why they can't sleep is because they just haven't had enough exertion during the day to actually make them tired. Like my mom is actually a perfect example. She's retired, and it wasn't until she started doing aquafit because her back started hurting her that she would have exerted enough during the day that she was actually tired at night. And instead of having this crazy insomnia where she wasn't falling asleep till 2 or 3 in the morning, she was falling asleep within 20 minutes. And so, you know, I think sometimes our arrows are bi-directional, and it can be this negative feedback loop where we're not sleeping very well. So our body is craving glucose. We tend to go for higher processed carb sources. And then, you know, we're not feeling tired, so we don't really exercise and we go into this negative spiral. But we can also have this positive feedback loop where when we change one variable, which whatever that variable may be for that individual, it could be exercise, it could be nutrition, it could be trying to do something else to sleep a little bit better. Now we can get that positive feedback loop and we can almost change the spin. So I think that's an awesome conversation because it's super, super important. And our role as physical therapists, this is something I think is super, super important and something that we can really clearly niche out a role for ourselves in. And we just haven't done that just yet.
Yeah.
Cool.
Nikki?
I think too, going with like the protein and sleeping, being a therapist within the senior living community, I think, you know, I was talking to Avery on the side about how many clients compensate and are living out in the community by themselves. And you're really surprised when they do come in to the clinic or move in, how weak they actually really are and how they've been compensating and living independently within their home. So I think that like a senior living community is really a good outreach for people, and they kind of look at it in this negative connotation, but they get 3 meals a day that are protein rich. Then if they're getting, meds given to them, at least they're getting hydration. Or if they're coming into like our gym, I'm always educating about hydration because they really never drink enough. They might only have like that 1 glass at breakfast and then with their meds. So I find that dehydration is one of like the biggest issues that people get sent out to the hospital when they're in the senior living communities. But yeah, I'm always educating about like nutrition for sure. So if you have any of your home health clients and you're seeing them really struggle, definitely like look into what communities are in the area and just set up a tour. And you can, be helpful in that stepping stone or education to the family, that it's really not a skilled nursing facility where it's the end all be all. It can almost be like a respite stay if you're seeing somebody that's really, really struggling within their home.
That's a great point. Very good point.
All right. Okay. So how would you handle a regression? So we've talked about, potentially doing a little bit too much, having individuals come in with flare-ups and pain. How do you kind of handle those conversations when sometimes you have a client who's fairly angry at you for potentially flaring up a joint or, increasing their perception of pain for the interim time between when you see them? Dustin, it's just you and I who have ever flared up a client.
Seems like every week sometimes. It's like, oh, okay. Let's dial it back a little bit.
Ryan?
So I just similar to what I said earlier, I would just explain to them, maybe we did a little bit too much. Let's just back it down a little. Let's just decrease the weight or decrease the reps. And then again, I would, do something for pain modulation, whether it be joint mobs, or I don't do a lot of E-stim, but if people do a lot of E-stim, they could do that, or, whatever to help modulate the pain.
Yeah. Avery said, I remind them that I want to be at that line of demand and load. I hope not to cross it too far, but we need to be approaching it or they won't get better. And that's that tough spot that we're in, right? We're trying to push them. Dustin does a great job with, is the ankle pump dangerous? Because when we have those individuals who are so close to that line of loss of functional independence, which just like Avery alluded to, and Nikki was talking about, sometimes the people who are coming in, even to an outpatient clinic, and you start looking at how they're doing things, you're like, oh man, you are very close to one fall or 1 week of deconditioning or one flu really, really impacting your ability to live independently. That type of education line where the ankle pump can be dangerous because we actually do need to be loading them to increase that reserve as fast as we can, because their trajectory is about to take a down spiral.
Oh yeah. Avery, just type if I screw this up. Avery mentioned, so Avery was at the sampler in Las Vegas this past week. Was that last weekend? That was a week ago. That's crazy. And he was talking about a patient that came in for neck pain, I believe. That was their chief complaint. And that's, what he was assessing. But, he was kind of doing his neuro screen, and he did their grip strength. And like he said, 10 kilos, which is like super weak. That's a red flag. When we talked about 1RM living and really leveraging these screens to really triage a list of what we really need to focus on. Yes, that neck pain, I can't remember, if it was, one-sided arm pain or whatnot. I can't remember the symptoms, but coming from the neck, we'll say cervical pain. So that is an issue. We need to address that for sure. But while we are addressing that, how can we increase their strength and their functional capacity, to protect them from some type of functional decline out in the community? But Avery may not have known that if he didn't have, checked that grip strength, for example. which is huge. So yeah, Avery said she turned 90 the day before I saw her, living independently currently, and wants to stay there. Feels she is in really good health overall, which I think Avery mentioned, like she is doing pretty awesome in the grand scheme of things. I mean, she has some neck pain. She's 90 and still independent. Like that is awesome. We can't forget that, but she still has potential, you know, to continue to have a high quality of life for you know, many more years. So Avery's in a good spot to be able to really change that functional trajectory that you all have seen probably hundreds of times now in the slides.
Yeah, and even with the kind of going back to week 2 with the clinical geriatric syndromes, we know that under 17 kilos is a diagnosis of sarcopenia, especially if there's muscular atrophy present there as well, which probably at 90 there would be.
Yeah.
My grandmother's 93. She was just at my baby shower today too, and no gait aid, drives on her own, doing just awesome.
Boom.
Jen?
Yeah, so I was just kind of wanting to inquire a little bit about this, like bringing patients and doing too much with them. I had a patient she's in a like independent living facility, and she's 85, and she comes into the outpatient clinic, but she has such severe knee arthritis and back and shoulder arthritis. I mean, when she stands up, it's like a creaky door, you know, it's like, it hurts me to hear her move. And she's been having a couple falls, and I know that she needs to get stronger because she can't get up from any surfaces. She goes down to the dining room and she can't get up from those dining room chairs. It has to be her lift chair. So I, tried to work on some strengthening things with her. Felt like I was loading her well enough, but she came back in and she told me that I had so much more trouble getting up the next day. Like she wasn't sure she wanted to come back, but her daughters really encouraged her to. So, you know, I guess I wanted to ask you guys what you would do in a situation like that, where you know that she has such a degenerative condition that's probably obviously not going to get better. She's not a candidate for knee surgery or anything like that. Would you continue to work on those things that cause her pain, that loading and all of that?
I'll give my 2 cents because I got someone
question.
tomorrow morning that fits this. Well, where are you? Did you say you're in an assisted living facility?
So she is in an independent living facility that has a continuum of care, but she's in the independent living side of it, and she came into the outpatient clinic. She had just finished home health a few months prior and sort of regressed a little bit and was having more difficulties from her home health stint, and so she came into outpatient.
Okay.
But she also has a significant copay, so she can't come in very frequently. She's only able to come in like once a week.
And they have a gym, I imagine, that they can use whenever.
They do.
Okay. So I'm in a similar building and have a similar patient. And yes, it seems like everything that I want to do increases their symptoms, very painful. I think in that scenario, and I'd love to hear everyone else's thoughts on this because I think we've all seen this type of person. But what can they do where they are moving and challenging their body without the increase in those symptoms? And that's where I really like to look towards something like the new step, like a recumbent bike. Some of those pieces of equipment that may not have as much weight bearing, but we can get some movement, some active range of motion, and some load, and kind of ramp up the intensity there. So that's where I found the new step has been one of my favorite pieces of equipment in our facility, to throw someone on there to where, they probably could benefit from, some type of kettlebell goblet squat that I would love to do with them. But, it increases their symptoms dramatically. But maybe we can get on the new step and, have them just kind of put their hands on their lap or across their shoulders, and they can do, basically a leg press in a much more tolerable manner. Yes, I can't load it up like I could potentially with something, like a kettlebell, for example. But as time goes on, you can progress the intensity, you can reduce the rest. There's different variables that we can manipulate there. to get some type of stimulus that will get some type of adaptation. That has been helpful, but I know, that's an N of one for me. But I think about those types of equipment, how you can use that to really ramp up.
Would you still recommend that, like, as you would like strength training? If you're really working on strength training, it shouldn't be an everyday thing. But since you're kind of doing more of the new step, would you encourage them to do that every day still?
It depends on how they respond. Like I would love people to get, moderate to high intensity, exercise every day if they're tolerating it well. But that may be something of, okay, today we did, 10 intervals at, that number was 5, that resistance was 5. If you do this tomorrow, if you're feeling great, you can send it again at level 5. If you're a little sore, maybe pull that knob that's down by your butt back to, 2 or 1 or, something like that. So you could even, vary the intensity based on the days. But I think a lot of that is the conversation of how they're responding. For a lot of my folks, because they're so sedentary, I'm wanting them to move every day if they will, to encourage that. Just because the longest walk that they'll do sometimes is only 150 to 200 feet from their room to the dining hall and back. And they get, an hour break in between that, with their return walk. So daily, if they can tolerate it, and then fluctuate the intensity if that's an issue.
Yeah, Jen, I see a lot of people in the outpatient setting. So this is completely not evidence-based, but it has worked with so many of my clients. If I have individuals who come in with very severe arthritis, and they have muscle soreness in a muscle that is crossing over an arthritic joint, sometimes like just the tightness that happens as a result of resistance training, that normal tightness on the injury, it just flares them up every single time. So what I get them to do is honestly get a rolling pin. And I've said, when you get home, one of the things I want you to do, especially if your muscles are starting to get tight, is just roll out your legs. Right now we know that foam rolling, there's the evidence is usually around the neuromuscular adaptation for instantaneous change in length. But I look like a physio magician because it instantly releases some of the discomfort on the knees because the quads just aren't as tight for that, even that short amount of time. And then they have like a self-management strategy for if their muscles are sore. Because I kind of educate saying, we're trying to strengthen up muscles that are crossing over your joint that has a lot of arthritis in it. So there is some injury there. So when these muscles get tight, they start to pull on the joints that already have some stuff going on. So I'm going to give you this management technique. And most of the time I can still continue to load. And even sometimes in sessions while they're resting, I will get them doing that foam roller with a rolling pin, and instantly lets them continue.
And if they believe it'll work,
one of my tricks to try.
Probably going to work.
Yeah.
Aaron said, we have a warm water therapy pool and an Alter-G. Aaron, are you just rubbing that in our face right now? I think that's what you're doing. That I love for higher irritability patients. Andrew said, we just got an Alter-G and the patients love it. Easy to get them moving without the painful joint loading. Unfortunately, I don't think it does a lot for truly improving their muscle strength and power. Avery says, build the bike slow. Perhaps aquatics, new step is nice. Manual therapy, a lot of education about exercise pain versus damaging pain. Avery, do you remember what Jason London shared, the cheap version of the Alter-G? Have you all seen this? It's like this, like a rack that will go over a regular treadmill, and there's a bunch of bands that will connect to a belt, a waist belt, that unloads the patient. It's like $3,000, much cheaper than Alter-G, but you can adjust the percentage of weight bearing based on the bands that you connect that. It's like a climbing harness basically. I will get that from him and post that in the Facebook group. Yeah, for those that don't have an Alter-G, this could be a good alternative for these types of folks. I will probably never get any of my patients on a treadmill. That's a death sentence for many of my folks. But y'all that can, keep at it.
All right. All right, I think we're going to leave it there. This was an awesome conversation today.
Yeah.
I think that there's a lot of information being exchanged. There's a ton of ideas going back and forth. This is what gets me super jazzed up and high energy about this course, because we just get to learn so much from each other. Does anybody have any last comments as we kind of go into the next unit, go into unit 3? No? Okay. So
I'm so sorry.
Keep up the great work.
Oh, I'm so sorry. I know everybody probably wants to go, but I was really hoping that at some point maybe you could post a video or something for a little bit more maybe variations on the deadlift, or maybe how you do it, Dustin, in the home health setting when you don't have that equipment to put, something up higher. That's kind of the newness to me, is doing a little bit more of that stuff. So I was just hoping for a little tips and tidbits on those things, some variations, or if somebody doesn't have good form in their back, would you even do it? Those types of things.
All right.
Yeah, absolutely. Quickly to answer that question for you, you can just use a chair even with a kettlebell and get them going down to a chair or down to a step stool if you're in home health, whatever the person may have around the house. And what you're looking for in terms of if people have really bad form is there any change in lumbar position that could increase their risk for injury? So if they are, kind of moving through their back, then we kind of want to be very careful with our loading strategy. But if they just have an increase in posterior pelvic tilt that's been from 25 years of back pain, we're probably not going to be fixing that, even though we ideally would like a little bit more anterior pelvic tilt. So that's kind of the optimal, not perfect side to it. But we can definitely do a little bit more work on that.
For sure. Yeah, usually I'm loading with a kettlebell, and I'm trying to bring the floor up to them. So whether it's thick books, a stool, whatever flat surface I can find to where it decreases their range of motion with that kettlebell, that's usually my go-to with that, or a chair or something like that. But that's something that we can grade. But yeah, just echoing everything that Christina said too. So cool. All right, I'm digging about that treadmill accessory, and I'll post that in the group with the link to the recording for anyone that's curious.
Awesome.
Cool. All right. Well, I guess there's a show on right now that everyone wants to watch, so I'll probably go to bed at 9:06 p.m. Mike Quinn is just getting the day started over there, so good stuff. All right, so we'll see y'all in a couple weeks. I will have just ran and walked 50 miles, so I will be miserable. Christina is going to be birthing a human the day after that meeting, so I'm hoping she will not be on this call in 2 weeks. But knowing her, she's crazy enough that she'll probably try and hop on. But either way, we're going to have a call in a couple weeks, even if I can't walk or if Christina's birthing a human. So.
Or Christina can't walk.
Yeah, or Christina. Cool. All right. Y'all have a good night.
Bye, guys.
See y'all.
Bye, Christina.